All right. Thank you, everyone. We're going to go ahead and come back from lunch and get started. So does anybody need to stand up and stretch? Has everybody finished digesting all their food? Yeah? Oh, thanks. See, watch, follow Dave. Jesse. He's leading us in some opening stretches. Part of the reason I want to make sure everybody's awake is because we have an amazing panel for you right now. We have some of our thought leaders in the revenue cycle space with us today, some people that we don't normally get to see here because their time is so precious, but they carved out some specific time for us. Some have traveled great distances to be here. Others have had to beat off leadership teams and board members with a stick to be here. My name is Sarah Lucas. I am with Stability Theory Consulting, and I have the honor of facilitating this panel. I am currently a board member in the 23-24 year for Washington, Alaska chapter. But before we get started, I want to have a quick couple announcements. If anybody needs CEs, please do that at the red iPad at the back of the room. You need to sign in and sign out. Also, we really value your feedback. We read it after every session, or after every conference, and we really use that to improve the content, and we also provide feedback to our presenters. So please take time to make sure that you are providing that feedback in the app. And now I would like to, normally we announce our speakers, but I would like to give our speakers a chance to introduce themselves, and we've went ahead and put their little pictures up there with their logos and titles, but please just take a minute to tell us who you are and your role and something fun. Elise?
All right, I am, actually it's Elise Myers. The S is like a Z and the E is like an A because it's French. And no, I'm not French, so in case you're wondering. So I'm the Vice President of Clinical Revenue Integrity at Providence. I've been there since about 2012, but prior to that, I worked as a consultant there and at Swedish, so some of the people I see in the room are some old cohorts as well, which is great to reconnect. I oversee all of the, what we call mid-cycle functions, so HIM and coding, our clinical documentation integrity program, our revenue integrity program, and our charge masters. So we have about 1,000 caregivers who are in my group, soon to become part of another company, but we will still be serving the mission of Providence and still actually be doing the same thing after we transition. So that's me. And when you said exercising, I'm actually a dancer as well, and so if you turned down music, I would have gotten up and danced. I don't karaoke though, so.
Hi, I'm Jen Michaeland. I'm the Vice President of Revenue Cycle at Multicare Health System. I've been with Multicare for nearly 30 years now. I have responsibility for all areas of Revenue Cycle, from registration through all the way to the end, collections, and including utilization review and CDI, HIM, all of that. Fun fact about me, I'm still working off European time zone. I just got back from a ski trip in Austria, so I am trying to make sure that it's not, middle of the night for me at this point. So if I go to sleep, just tap me, Elise. Yeah, thank you.
I'm Josh Wood, Vice President of Revenue Cycle at Confluence Health out of Wenatchee. We serve about 12,000 square miles in north central Washington. We've worked hard over about the past 4 years to kind of build a more holistic revenue cycle. So when I started, it was more just the back end stuff, and now we're over scheduling, registration, et cetera. So more end to end, which is, I definitely think, the model and the way to go. So been with the organization about 6 years now. And I don't know if I can be called a thought leader. I try to be a thought follower, Sarah. Imitation is a great way to win the game. So, but I'll cross my legs the other way. So, I'm a thought leader now.
Great. So I'm Suzanne Vanderwerf, and I have been with Seattle Children's for 30 years, Vice President of Revenue Cycle and Health Information Integrity. And probably unlike the earlier presentation, I made a choice years ago that I'm all about Seattle Children's mission and not necessarily trying to build my career in other ways. So I have been there by choice because I love the organization. And like Jen, I have a very similar breadth of scope, just a single hospital with multiple clinics as opposed to multi-hospital system. And I would say that my passion, which most people know it's the way to my heart, is I love corgis. And I'm on my 6th and 7th corgi, and I just think they're the most fun dogs ever. Oh, no, 6th and 7th. So, no, oh my goodness, no. 6th and 7th.
I was like, 67, either you have a farm or you shouldn't have them anymore.
No, that's too many.
No, 6 and 7, that's wonderful. Okay, so let's go ahead and get started on our questions. Great. So, clinical denials and denials overall significantly impact revenue cycle. We know that they are changing all the time, they're increasing, and they can cause not only disruptions in the workflow, but hold up a lot of revenue. And we know that every claim that is denied increases our cost to collect significantly over time. We're constantly looking for ways to reduce those denials, whether that is analytics, personnel resources, looking at EHR tweaks, et cetera. They are getting significant, though, increasing, and it's taking longer and longer to collect. There was a time when we continued to see AR days come down and down and down, and we saw record lows a few years back, but we're not reaching those lows again, or at least not right now. I don't see anybody really reaching them, and we're seeing a new normal. So the question for our panelists today is, what are some of the most notable denial trends you and your team have identified in the past 6 months? How were the issues able to be resolved? Or if they haven't been resolved, what is being done toward resolution? And what are the lessons you've learned? Anyone can answer. Josh?
I guess I'll bring kind of a unique perspective in here. We actually have had really historically low denial trends, but which is great. It's very hard to maintain, and actually a couple of years ago our denial percentages doubled over a few years, and we were like, oh no, and then we looked, the whole industry had gone up the same amount. So it does seem like a losing game sometimes. I think it was Sean talking about that earlier. The trend that I see is that it becomes just more and more difficult to prevent them, and that has been our primary strategy. We spend so many of our resources and revenue cycle at our organization on the front end, educating our front end managers, our registration, et cetera, and we can still not keep up, you know. So that I think is a key trend. The other piece that I've seen has been actually fairly unique to a situation we've had in Confluence, where we consolidated our entities, and that kind of caused mass confusion among our payers. As hard as they've tried, and even Noridian, we're still struggling with not necessarily denials, but RTPs. So it seems like our ability to make change as an organization and how we're organized, or any other way, even our provider rosters, et cetera, is hugely hampered by the complexity of navigating all of our different payers and the different rosters they need, and all the information we have to update differently for every payer, so that for now 3, 6, 9 months since the changes we made, we can still barely get some of the claims out the door. So I guess the second trend I will call out there is the complexity of being able to make any sort of change and get the claim right. Mm-hmm. If everything stays the same, it's great. Especially with Noridian, if you don't make any changes, they're a great payer. They pay fast. They pay the full amount. They'll come back 2 years later and take it back. But what we're finding is, you try to make any change to make your organization better, and all of a sudden you can't get a claim out the door. So.
So
So I would add to that many of you may have seen there was a study done by Crow Healthcare on denial trends, and Washington State was 47th worst state for initial denial rates. I know for us at Multicare about a year ago, we were getting gold trophies in Epic for our low denial rate. Sometimes we were diamonds, which that gold trophy, for those of you who may not know, is top 5% of Epic. And diamonds are being in the top 10, so they recognize you as a high performer. So we were consistently diamonds and gold trophies, which was wonderful. Since that time, we've seen almost a doubling effect in our denial rates. We're still getting bronze trophies, which is great, but not where I want to be for sure. And the largest areas of denials that we have seen have been in medical necessity. Lots of denials for cases that, by all intents and purposes, meet CMS's guidelines for being an inpatient, but where we're seeing payers deny them. So it's a tough business to fight every single one of those, right? It's a volumes game, and it's an expensive one because it requires a nurse or a provider in most instances to help articulate the need for the care that the patient had. So for us, we are trying to package those together and work on those in groups with payers to identify the trend. Certainly if the payer believes that the patient shouldn't be an inpatient, then our next question is, what are you going to do to help us get the patient to the appropriate level of care from your standpoint? Because this can't be a game where you leave your patient in our hospital and then you don't pay for them. That doesn't work. It's got to be a partnership where we work together. Alternatively, though, one of the things that we've been really focused on is in our physician space. Registration is an area in the physician space that does not report through revenue cycle. It is largely managed by our clinics. And we found that we had a significant amount of registration-related denials. Over this last year, we have been really targeting that through education with the clinics about the importance for them to do accurate registration. We've been feeding back to them the denial information we're getting from registrations. We've been providing them the mail return information that we get in their clinics, and we've been asking them to follow up with patients to get corrected addresses. And what we have found is we have decreased by half the amount of denials that we're getting in our clinic setting. So we're losing the battle on the hospital side, but we're winning the battle on the physician side. We're going to continue to battle this because we want to make sure that we're doing the work that we need to do to get paid for the services that everyone has provided. But it is tough when you look at your state and you see that you're in the 47th worst state for initial denials. Very disappointing.
These other states are bad as well. So, unfortunately, I think as far as other trends that we're seeing is the hidden denial. And so those of you who deal with lots of denials and underpayments know that payers are not always upfront about denying your claim and instead are just paying you at a lower rate. It could be a lower DRG. It could be just a lower rate than what even the fee schedule dictates. And they don't communicate that in a denial form, so you have to have the analytics to know whether or not you're being paid appropriately. And that takes having a pretty robust, tool or analytics capability to understand that on every single claim. I think like Multicare, because of size and volume, we cannot fight denials one by one. It's a losing battle. Nobody has that kind of staff. And so we are actually packaging our denials and underpayment trends that we're finding and approaching payers not alone, but actually with our payer contracting team now, because if they're not going to pay us on the back end from the denial standpoint, the claims process, then they better be paying us up front, in terms of changing the rates. Because at the end of the day, they need to pay for the services that we're providing. So I think it's really trying to come up with new strategies and tactics for, you may have to go to a legal action. You may have to go to a contract termination in your payer contract negotiations. But, the money that they are making on the members that they're supporting is just doesn't make sense when you look at the financial picture. The providers really are in a losing battle right now. I think the other thing that we are trying to do is really focus on those root causes. So in my space, since it's mid-cycle, what is the clinical documentation that we really are providing? Are we providing as much robust, accurate, complete documentation in a way that is going to allow us to be in a good, strong defensive position when we do go to fight those denials, and when we show the payer that, yes, indeed, we actually did perform the services and they need to pay, or the patient really is this sick and they need to pay at that higher rate. So those are other things, but I think those analytics are kind of really critical to being able to understand what is really going on and how do you fight things not at that claim by claim level.
I would add to what was already very articulately said is our top denial reason far and away is needing a copy of an additional piece of documentation. Just no contest. Most of our claims at Seattle Children's in the inpatient setting are going to cross payer thresholds for audits. And we are increasingly in the situation where we are not allowed to send that documentation. We know it's going to be needed. We know it's going to be audited. They will not let us send it, because if we sent it, then it would continue to be a clean claim, which had a timeline to be paid upon. And if they can create a denial for us, then the clean claim timeline goes out the window, as well as most of the contract language, which we're trying to change, and we're on their audit timeline. And right now that audit timeline is typically waiting between 2 weeks and 30 days for that first denial to send that information we already knew that they needed. Audit timelines are taking 2 to 3 months. Then we get the results, and the payment still doesn't follow for another 3 to 4 weeks, which creates a 4-month timeline and is very reflective in AR days when you just have the majority of your AR in these inpatient admissions. So we've really taken some efforts that we're trying to bring greater visibility of. It's unacceptable that you aren't letting us send the documentation to you when you've already outlined in your policy you're going to ask for it. So this is unnecessary delay that we cannot proactively send it, and we are continuing to advocate for that through the Hospital Association as well as directly.
Starting in 2020, February, when COVID shut everybody down, staffing became a very large issue, and it grew and grew and grew until 21, through 21. But it hasn't stopped being an issue, and I think we've gone through cycles of what that has meant, whether that was sending everybody home, trying to get everybody back in the office, dealing with huge increases in nursing, traveling nurses, not being able to find even outsourced companies that could fulfill the needs we had in certain areas like coding, et cetera. What are the trends that you are seeing now in staffing, whether that's how you're getting staff to your organizations, how quickly they're leaving your organizations and why, whether that's outsourcing trends, et cetera. What's that look like for you in your organization today? Anyone can start.
I'll start since we're doing a lot of this. When COVID hit, we actually moved everybody home. We already had quite a few people home, as I think most people did. Coders typically worked from home. But we moved really, I would say 95% of our staff that is not patient-facing, we moved home. And that actually helped quite a bit, because now suddenly people had more flexibility in their schedules. And we still, we always manage them via what they do in our system, so we weren't like actually standing over their shoulder ever managing them. So it was not a hard shift to make. But I think the biggest thing that our company ended up doing, we cover a 7-state footprint today, but we expanded our hiring capabilities, since we are 95% remote, to about 30 plus states. And especially states like Florida, where, they just, I don't know why, they have more coders for some reason. It really made it a whole lot easier. So we've been able to maintain, in my space, about an 8% turnover rate. And we're able to, let people stay working from home. I think when you start looking at outsourcing options and, what does that actually bring to the organization? For us, it's not staffing because we have the staff that we need. But for us, it was more of a technology need. When you work for a big company, I can't remember who, I think we were talking, Stephen, about how many layers of decision makers you have to go through to get a simple, technical decision made at a company. This really does, for us, for Providence, is going to give us the advantage of more technology, a company that has technology capabilities that we don't have, but also who can maybe move a little bit faster than a company that has to worry about the doctors and the clinics and the hospitals and so on. So I think, that expansion of making the pie bigger is actually going to be more critical to our success in order to have the right people at the right place with the right skills, and then the right technology also to supplement. We did go down a global sourcing strategy as well in our coding space. That's been very hard. Anybody who's tried it knows it's not a 6-month endeavor. It's a 2-year endeavor before you can kind of get it right. So that will continue to be part of our strategy, but anybody who is interested in doing it, just know that it takes a while to make it work. So that's something we're going to stay involved in with our new organization that we'll be working with. They'll be employed offshore workers, and I think that'll make a difference as well.
I guess I'll chime in. Well, actually, going back, so one of the things I love about a panel like this and talking about trends is you find out a little bit along the way what the trends are too. Hearing from you, especially about the down coding, for example. But speaking of staffing and outsourcing, coding is an interesting one for us as well. That I think was already moving towards a pretty remote work dominated market prior to the pandemic. And obviously it became more exacerbated during the pandemic and continues to be that way. Maybe that's a negative connotation word, but what it's created is the market for a coder is the whole United States, which means if you can't compete with the East Coast wages, you're not going to get anybody from the East Coast. So thanks for the tip on Florida. We'll wrote that down. But we have also been looking at opening up states, where our payroll shop's not huge. They've got to figure out the tax law, and so that's been a consideration for us because we're just not a huge hospital. We're about 200 beds and 400 physicians, but. So coders being part of the national market, we've opened up states when a coder wants to move, they're like, oh, you're moving to Arizona. Well, let's look into Arizona and see if we can keep you. And so that's been some of our strategy. Another interesting staffing trend that's hitting us, because staffing's come up a number of times in the conference already, and I will say it's still a challenge, and I don't know when it's going to go away, because if you look at demographic aging charts, frankly, we're aging out of the larger populations of employable people. Each generation is getting smaller, not larger. And that's going to eventually be a problem, maybe not in the next 5 years, but definitely the next 10 or 15. I won't get ahead of myself with AI in that case. But so I guess, I would love to have this optimism that staffing issues are going to go away. I don't think they will. We've got to adapt. And one of the places I see this also is with minimum wage laws, which I don't have any fundamental problem with, do cause wage compression, which is a challenge that we have to deal with. And it's not an easy challenge, unfortunately. 5 years ago, our ED admitting reps made more than somebody at McDonald's because it's a hard job. Now it's basically a McDonald's wage, and we're like, oh crap, we got to do something about that because we can't keep ED admitting reps, which is a big problem if you want to remain a viable hospital, right? So those are some of the trends that we're seeing.
I would, I think you both made great points, and I would really advocate for those of you who maybe are considering bringing people back into an office, I would advocate to reconsider that for revenue cycle. I think it has been great to be able to hire from a larger market. We've been able to, same thing, our revenue cycle is largely remote. And it has been very successful. Managing productivity has been fine. There's been lots of technology that's been put in place for us to collaborate with one another and popping in via Teams works well and allows for those impromptu conversations. But one thing that I want to share that's a little different is something that we put in place at MultiCare prior to COVID, and it was something that I didn't realize what a benefit to us it would be. But I'll put it out there as an idea for all of you, which is for our registration area, we had significant turnover, and I think that's pretty common for every hospital to have turnover like that. And one of the ways to combat the turnover was to hire on-call people. So each of our hospitals would hire on-call people. It was difficult to keep those people working and employed. They weren't getting enough hours. They were working inconsistently. So we decided to create a float pool across our hospitals. And so we've got a float pool for Puget Sound, which is most of the hospitals are in our Puget Sound region, Pierce County, South King. And then we had a float pool in the Spokane region. And this is mostly for registration staff, and it's designed to be the gateway for hiring people into the organization. It gives them a chance to try out several different facilities. They can try ED registration at a multitude of facilities or off-campus EDs. They can work in many different locations and see what might be a fit for them. So rather than having registration turnover happening in an individual department at a hospital, we have a float pool that becomes the gateway for hiring all people into the organization. And we have a manager over that float pool who is constantly hiring. That's their full-time job, is to hire people and deploy people. So they bring them in, they get them trained, and then they deploy them into all of the different hospitals. What we ended up having was these are people who are hired without an FTE. They're not being paid unless they work. But a majority of these people are working full-time because there's always so many hours that need to be filled on a regular basis. So in our Puget Sound region, we have about 40 people in these float pools that are working full-time, and we're having this constant transition of those people who've been trained and are knowledgeable getting hired into positions. So we have very little downtime, and when COVID hit, we were so well prepared for what we needed, which was more staffing in that space, and we had a pipeline for how we hired and got people on board. So just encourage you to think about how you might use a float pool. It's continued to be very beneficial to us in terms of keeping stability in the staffing area and not overburdening our supervisors to be those backfill employees, which is usually what ends up happening. So,
I think to the point of the turnover rate, that for me is as important a metric as AR days. I am constantly looking at what our voluntary turnover rate is, because by being a pediatric specialty hospital, there is so much we have to invest in training for people to have pediatric expertise, particularly in certain areas like coding, but also in some of our revenue cycle functions where we're addressing claim types that somebody could work 20 years in an adult hospital and hasn't ever addressed before. And to not be continually training and wasting that effort, we need to retain the good people. And so we do everything we can. My primary investment is in the supervisors, because people leave their boss, not their job. And they need to have supervisors that they want to stay with even when the work is tough, and the work will always be tough. So we are constantly looking at their turnover rate. And I often tell people I personally am actually physically a closer neighbor to Josh in Eastern Washington. That's where my main home is. So I'm 90% remote as well, but 10% of the time I go into the hospital and I say key meetings. And about half of those key meetings are what I would call team building social events, because this team is having a retirement party, or this team's having a baby shower, or whatever it is. And just doing that FaceTime, it's so key, because it's all about the retention, which is all about the AR.
So true. Okay. Josh gave us a little teaser to this, but the term AI and machine learning is everywhere. People are figuring out what that means for their space and what that means in general. And we heard a lot of talk about that at Western Region. During the think tank, there was a lot of discussion about how people are utilizing it in some really creative ways. And so our question to you, our panel today really is, tell us about what you're currently doing and how you're currently utilizing AI machine learning in your departments. Are there areas you're exploring new ways to use this technology? And what are some of the significant benefits or most significant benefits you've already started experiencing from where you've implemented it? Anyone can start.
We're not as far ahead as some organizations that probably have broader IT resources. I have learned with some of the things we have tried that I now am careful not to use the word AI around our IT team unless I can at least preface it and say it's not generative AI. Because as soon as they think it's generative AI, they want to shut it down because there's just so much anxiety about what that means for healthcare right now. So trying to be very clear, nope, this is just automation. It doesn't matter if the vendor has AI in their promotional materials. That's not what we're doing. But trying to leverage that. And we're still a little bit in the watch and see what the successes are of other larger, probably, organizations. I will say that probably our most successful effort this past a year, and it was one actually Jen and I were just talking about before this panel, is in the prior authorization space and being able to do some radiology automated prior authorization with a number of our payers really has saved us some time, but there's still so much to go in really having the promise be delivered upon.
I kind of like terrifying our IT department, so I like talking about. IT can be a bottleneck, and that's nothing against them. They are at the center of all our resourcing for everything we do in RevCycle, basically. So we do have to be careful about, what priorities do we throw their way. But yeah, I mean, the discussion of generative AI, it terrifies our compliance department, I think. But I think it is interesting because when we talked about AI 2 years ago, we were talking about something very different than when people talk about AI now. And in fact, most of what we named AI 2 years ago was really on the more rules-based and occasional machine learning area. And now you have these near generative AI large language models. And I'm kind of excited about the potential in revenue cycle. I think there is a lot of fear about what can go wrong, which I think we will probably flesh out fairly quickly, frankly. But there's a lot that can go right, and it's definitely not a panacea because it is a language model. It's not true AI, right? And what that means is it's going to be really good at certain things we do in revenue cycle and probably not at others. Some of those certain things, writing an appeal letter. I mean, that is the niche of large language models, is they take huge amounts of written data and throw it all together and synthesize it in amazing ways and pick out the important pieces. It's exactly what you're doing when you're writing an appeal. So I would love to see it applied to that stuff. I know Epic is piloting some of that stuff now. And another area where basically what you're doing as a coder is often that as well. And so I'm excited to see AI as a co-pilot to our coding teams. Coding's expensive. And it is literally our largest department in revenue cycle by quite a bit to get our coding right. So I think there's some areas I'm very excited to see there. I think if we are not as revenue cycle in the healthcare industry exploring generative AI in the next 6 to 18 months, we're going to be behind. And that's not saying we're putting it everywhere, because it doesn't belong everywhere. But there's a few places where I think we can make some big differences. And for me, with how hard we just talked about staffing issues, there is a lot of fear when you talk about AI because it's like, oh, is my job going to be eliminated? And it's more about, no, but you're retiring in 5 years, and maybe we won't have to replace you. Because I don't know about other people's coding department, but ours is kind of aging out, and it's a problem.
Also think I would add to what you're saying that denials aren't going away. And so while it may feel scary to think about AI and machine learning, the reality is there's always more complex work to be done. And so the ability to automate and simplify or let tools do the work, the more simple work, the better we will all be. Certainly an area that we're digging into. We have some solutions in this space in the utilization review area. We're working on it in the coding space as well. I would say we're very early in that, but working through the pathway, clinical documentation integrity as well. Prior authorizations, we do have some items in this space as well. So I think if we don't explore it, to your point, we will be further and further behind. We know the payers are using this type of technology, and therefore we have to stay up on our game on this.
I think what you said about this, how do you define AI and machine learning and natural language processing is, there's very different understandings or interpretations of it. Many of our, partner companies that we work with in revenue cycle are also looking at how do you incorporate these capabilities in their technology, because they have the same problem that we have is, staff shortages are a real thing, and staff make mistakes. So I think where we are looking at AI and machine learning and natural language processing is all of the areas mentioned, by Jen as well. Partnering right now with Microsoft and Nuance, Providence has a strategic partnership relationship, and it was interesting because I sat in a room one day with them where, they brought their kind of technical people to the meeting and their leaders, and we brought our leaders, and it was sort of like a whiteboard where, like, what ideas can you come up with to use this type of technology, and where are your biggest pain points, and is this something we should kind of collaborate on and build? So I think there's like so many opportunities. I think the hard part is narrowing down what is your most important, thing to tackle, and how do you make it be as safe and secure and not learn the wrong things. Like, machines can learn the wrong thing and over again replicate that wrong thing, like even more than your people can in some ways. And so there's a lot of just, I think, caution that people need to take around when they implement these types of technologies, that they're really verifying and validating. We, of course, use computer-assisted coding. We just recently implemented some additional automation in coding, more AI type of automation. But we're really cautiously reviewing because we want to make sure it's not making poor decisions. We are looking at it in CDI where we have actual physicians piloting, having as they document either in writing or verbally that the tool is integrated with Epic, where it's actually reading or listening to what the doctor is saying and real time giving that physician feedback about, hey, did you said this and this and this, but should you look at this? And it's kind of interesting because there's a balance between leading the physician that you have to not do and to stay compliant, but also it sort of like that person next to them saying, hey, you forgot to check this box. So we're trying to just very cautiously pilot some of these things so that we can figure out what's the value. Is it really going to make a difference? And will the physicians use it? And is it going to be accurate and compliant? So I think our dilemma right now is there's just so many things you could use this technology for and picking the right things. we work, of course, with companies that look at our charges and verify, did you capture all your charges? We can't do that ourselves. We build, tons of rules in Epic, but you can only catch what you can catch. And so when you use things like AI, you can start looking at behavior and what does this physician X always use for surgery Y? Do they typically use 2 screws for this procedure or 1? And they only documented 1. So did they just make a mistake and forget to charge for 1? So that kind of AI has been out in the market for a while, and I think a lot of people may not know that they're using it if they're using some of these third-party vendors. But I think we're really just novices at all of this right now, and I think it's really trying to figure out where can we go, where's the most value, how do we stay ahead of the payers, because they're also looking at this technology or using this technology. And then how do we just validate and make sure we're doing the right thing?
Really great points. Thank you. The new CMS interoperability rules around prior auth and interoperability in general are garnering a lot of discussion right now. And there's some concerns about everyone's ability to be ready, both ours and our business partners. Some have raised concerns about the industry's overall industry readiness. How are your organizations preparing for these upcoming changes?
This demonstration of payers not being ready is what Suzanne mentioned earlier, which is the number one issue with denials of additional documentation needed and the inability for those payers to accept the additional documentation at the time of the claim. So it is definitely concerning. I know for us, we did turn on a FHIR platform recently with a payer for prior authorization that we think will be kind of the foundation for where we're going with where CMS is going. And we're very excited about that. I can tell you that the tool works quite well, and it has significantly improved our production for prior authorization by being able to pull data out of the Epic system and directly provide it to the payer and get the authorization real time. So we're seeing some benefits there. But as we know, payers like to develop their own platforms, and that just increases the complexity and the challenges with IS&T to get those connections made and the systems in place. So I think we're on our way to where we need to be as a health system, but I do worry about where the payers may land.
I want to piggyback off the AI thing as a note here. One of my favorite uses of ChatGPT is asking it about new laws. So, and the great thing is, it's not just summarizing. You can go into the details, ask another question. Those questions build on. It's like having a conversation with an expert in the law, and that's actually kind of leading into this one. When this came out, I was like, oh boy, I'm so not excited to read all about that. But hey, ChatGPT is great. But I think for this one, I actually have a question for my fellow panelists. I'm wondering what role you all think Epic's payer platform is going to play in this.
Well, I'll respond to that because that really, for us, to your earlier point about limited IT resources, we don't have IT resources to be able to adequately host multiple platforms. And we have a very risk-averse security approach in our organization. So we made the organizational decision and have been very public with our payers that our approach is going to be payer platform. And if you would like to work with us on a record, we'd be happy to do that through payer platform, because we just cannot do multiple different tools. We will not be able to support it, and we can't take the risk. So we are set up with payer platform, and we're adding payers as payers become ready in contract, and we are having some conversations with our larger payers in the region saying, this is our strategy, we hope you will join us and start thinking about this seriously about acquiring it.
That's good to know. We also implemented Epic Payer Platform. We've been, Providence has a committee that is focused just on interoperability. There's actually a team. It's part of our population health group. And so we had somebody read those rules that we didn't have to read. But I think what we're doing is taking a multi-pronged approach, because we know some of the payers will not go on Epic Payer platform. A lot of the large ones are starting to now, and I think it's picked up some momentum, which is great to see. So we're adding payers as well as they come on board. But because we have so many payers in other states where they just won't, join Epic Payer platform, we also are trialing some of the multi-care. A couple of pairs right now using the standard national standard fire, specs as far as connectivity, and I think it is actually going really well. But we don't want to have 25 different versions of it. We want to have one, and so the choice is Epic Payer platform or this alternative fire, use the fire standards. I think that if we could get our top 20 payers across the 7 states to use one or the other, that'll put us in pretty good shape. But I don't think that the payers are going to be ready for what they need to be doing. And so some of these tools are going to be limited by, how ready the payers are. And, because why do they want to give up being able to deny all of our claims? I mean, that's cash out the door, sooner. So they're just dragging their feet. It's going to be very interesting to see what happens in 2026 and how much they lobby to not, to push it out even further.
I think that's the big elephant in the room in my head, is how many times will this get pushed out, right? And the reason I asked about Epic Payer Platform is we are trying to get that live now, but our largest payer by far has no interest at the moment in doing it. And I'm hoping this actually spurs some of those large payers along, because I have kind of the same thought. If we can get our top 10 or 20, with a few exceptions, hopefully not, but maybe, on payer platform, then we're in a much better spot for this. So yeah.
I would think, though, the ability for us to band together in terms of asking the payers to do that is going to be what helps us. Because I know Suzanne and I, when we were talking, I was like, well, are you pushing on Molina? Because that'd make all of our lives better. So that may be something we want to talk to the Washington State Hospital Association about as a group, because that will help us to get further on this pathway.
Great. So, does everybody know what a cyber attack is? Just making sure. We don't need to clarify definitions here. Actually, at this conference last year, we had we had a provider and their vendor and a security expert, a lawyer, present on a panel about the moment they realized they had been hacked. And what happened. Many of you I see in the room were here and remember that conversation. And so here we are a year later, and everybody in this room has been impacted in some way by another one, whether that is in business or inability to get Walgreens to process your prescription. Yeah, and having to pay out of pocket. So in some way, we've all been recently impacted. And when we put this slide together, we were like, oh, well, it may not be relevant in a couple weeks, but I think it still is. I just saw a headline yesterday about somebody asking the government to step in and start paying hospitals in the interim because of the billions of dollars being held up. And so really what we just wanted to talk about is not so much that one payer, not that one organization. They're not the only ones. We've had several others in the last year that have experienced attacks, even locally. But really, as a leader in revenue cycle for a healthcare provider, how is the implications of this impacting your daily operations? How are you incorporating this into your decision-making process, and how is it impacting your culture and even your patient communication?
We were impacted recently by a local hack that wasn't with Providence, but with one of our partners in the lab space. Some of you probably know who I'm talking about. I think that we actually recently requested I requested an internal security review of our policies, our processes around use of things like SharePoint. Believe it or not, you can let somebody into your system via SharePoint and have no idea you've let them into all your folders and files, and it's very easy to do. And so I think really education, making sure that you are checking yourself and that you're verifying that any potential entry point, whether it's via your help desk, via your collaboration tools like Microsoft Teams, et cetera, that you just have to be vigilant. We're talking earlier that, our IS team also sends out, spam on purpose, phishing emails to test us to see if we're following the rules around don't open things that you don't know who they're from. But we have to do that, because if we're not doing it, it's very easy to be subject to these attacks. I think all of us have probably been subject to way more attacks than we know about, because I think all of us have cybersecurity teams that are now, checking and stopping things from happening before we even become aware. But it's just that vigilance, and then immediately reporting if you think something is wrong, because the faster you can catch it, the less damage you can have happen. So that's what we've been focused on at Providence. And any connectivity that you have to think about, if that connectivity went down, what's my alternative? What is my contingency or backup plan? We used to worry about this with servers, right? When a server went down, did we have a failover to a different server in a different geographic location? Now everything's in the cloud, so now the concern is, do you have an alternative solution to every single major process that you have in your organization? Because if you don't, you're subject to things like, I can't get my claims out the door, I can't get my payments in, and so on. So I think that's really the next thing that we have to be focused on.
Yeah, I think in this space, when we think about us and them, the them is the threat actors. And we've got to be together on this. And I think that means, every company, whether it's a provider or whether it's a business partner, we all have to do everything we can to try to prevent these, even though we know that they are inevitable. For the ones we have experienced, and we have experienced both, of course, this recent one and a previous business partner that we had with us. And my CIO's first reaction is change them out. And I've had to push back and say, this isn't like switching out the Coke and the Pepsi machine. It's not that easy. And it doesn't necessarily mean that they, quote unquote, did something wrong. I actually love that he asked me he sent me names of new EDI vendors last week, and I said, you realize we don't use the one that was attacked. Anyway. But I need my business partners to be doing everything they can to close the loopholes on their side, and business partners need us to do the same. Like, we're in this together, and I really hope a lesson learned comes out of this is that we need the payers to be in this with us. So years ago, when I remember revenue cycle many decades ago, I'm not as old as you may think, but I started young. There was the concept of PIP payments, periodic interim payments, and we all have typical amounts we're getting from those major payers every week. So if the worst happens, we need to be in this where payers consider send the typical amount. They're perfectly capable of doing offsets. They do them all the time. So there's no reason some of our payers, as we start thinking about this, shouldn't be considering why are they not sending payments. And in fact, I think the AHIP leader yesterday made some sort of comment about how, payers since day one have been, aggressively accelerating payments. I'm not sure to whom, hasn't been my backyard.
One thing that you just got me thinking of is I think it would be naive of us to think of this as an if event for anybody. I think it's more of a win. Whether that's one of your partners or whether that's your own organization. I mean, this terrible thought of what if Microsoft gets hacked next, right? That's everywhere. I mean, we haven't seen this much of it yet of something like that happen, and it's not impossible, but we feel like it is. And I don't even know how you'd start planning for that. One of the things that was interesting about recently was, at first when I heard about it, I'm like, oh, well, we'll be fine. It's just RT. We got downtime procedures. And then we started realizing, oh, but our payers use them to pay us. Well, that's a problem. And then you start to see how interconnected things are when you go to Walgreens and you pay $300 for blood pressure meds. That was a surprise, so I think having the foresight or at least the willingness to have that discussion in your organization where we're not afraid to talk about, okay, well, what if this major vendor goes down? Because that what if is much more likely than we would all like to think. I think one of the pieces of the question you asked, Sarah, was kind of how does this make us think about relationship? How does this affect decision making? I actually see huge advantages, and I think we all do, to consolidations of our partnerships. The fewer organizations you have to work with as a bolt-on to Epic, for example. Well, Epic is a consolidation, right? Almost. It eliminated a lot of things when we went on Epic. And then we have a different business partner for just about every piece of the rev cycle. I've always looked at that as a downside. Because there's a lot of efficiency that's lost, even though some of those are best in breed products, which is great. And so that leads me to say, oh well, consolidating a partnership is maybe the right way to go. But then you realize, well, that brings other risks, and now that's not a reason not to do it either. But we got to go in eyes wide open, and I think to all of the points that have been made. Actually have those planning conversations to say, okay, what is our downtime procedure if we can't send a claim? Or anything, right? Yeah.
Or heaven forbid, your entire EMR goes down and you can't access medical records from any of your patients.
Well,
Or heaven forbid, your entire EMR gets hacked and you can't access any medical records for any of your patients, period.
yeah, I use the
That has
Microsoft
happened.
example, but I'm curious. I know there are a lot of Epic organizations in the room. Who is Epic hosted? Anybody? Yeah, we are. And we got fail-safe for our internet connection to Epic. But what if Epic goes down? And I know they've got like 3 different bunkers with their data centers. I've seen them.
Or Community Connect,
But
like dependent on somebody else who could get hacked.
we're all interdependent, and that's that. I think more than anything, we just realized that. So.
Thank you. So we're going to open it up now to the group for questions. If you don't have questions, I have extra ones, so no pressure. But I'm pretty sure some of you know the panelists up here, and I heard some rumors that there were some pre-planned questions for the purpose of torture. So I will probably come to you, or we've got some mic runners as well. So please stand up, tell us your name, your organization, and let us hear your question.
Sure, thank you. I'm Raj Verma. I'm a CEO and founder of Affable BPM. We do the automation of back-end processes using AI. Great discussion, amazing. Thank you so much for sharing a lot of these details which are so important when you are adopting AI or you are doing the automation or how the BCDR should work and all. So thank you. As we are learning the whole day today that claims denial is such a such a pain in everywhere to lose so much money. As you are trying to use the AI, I have heard that the IT department had some issues, or we cannot talk generative AI. We cannot. Can you please share 2 fear factors that each one of your organization has related to AI/generative AI?
I think one thing I would share with you that I've experienced so far as we think about, I may be a little adjacent to your question, but I'm going to start here, and which is we were looking at using machine learning AI tools to help us with our denials and help us to, for example, coordination of benefits or registration related denials. We were looking at AI to help us with that. And one of the challenges that we uncovered as we started to look at that was, as we worked with a company that could help us build that out, they could design the workflow related to the rules, the way the rules needed to be written for a payer. And so then the challenge became, how many times are we going to have to write the rule to deal with the same denial code over and over again in each of the different ways that the payers needed the information done? And so all of a sudden you've taken work that's being done by, let's say, 2 FTEs, and you've built out the cost to write this rule and do it 20 times for your major payers. And all of a sudden it doesn't have a return on investment like it used to. And the reality is that the payers all want something a little bit different. And so for me, one of our challenges has been trying to get to a place of having a return on investment for the work that we would need in order to get the help that we really need. Because turning it on for one payer, just it isn't enough. The juice isn't worth the squeeze. And so it's a challenge for me, and it's a challenge for our AI provider to try to help us to get there.
Jen, let me ask you a qualifying question on that. When I hear that somebody's writing all the rules, to me that's automation, whereas AI would be you being able to upload the documentation of all those rules, and the AI would build it all out for you. So were you talking about automation in that sense, or were you talking about AI where you can have a server with something like ChatGPT, and I'm probably using the wrong term, and it comb through all your contracts, all of their regulations, all of their rules, and build all of it for you, or hand somebody the specs? Which one of those were you kind of talking about?
More about the automation side of
Okay.
it, and maybe less about the AI side of that. But I think it's the reality of thinking through kind of this automation of pieces
Exactly.
of revenue cycle and some of the challenges that exist when we're trying to do this for 20 different payers with 20 different approaches. So, and they're not always very forthcoming. So the
Yeah.
ability to give them all the rules that are being used and have them automate something, I don't even know that I could get
No.
all the rules.
No, and
From
I
the
would,
payers.
I would expect AI to be able to see your denials and learn what those denials are and be able to create new rules, or at least recommend new rules based on what's actually coming back.
Yeah.
But I don't know anybody that's actually there yet. So great
Hey,
response. Did anyone else want to respond before we go to our next question?
Yeah, I think one of the key factors here was we've got to find the right uses for the AI. And I wanted to clarify the question. Was it more the barriers, perceived barriers to using generative AI in the organization? I mean, to answer that real quickly before we move on, for me, I think there's a lot of misunderstanding still. People do not understand what we're working with. Some people think it's total magic and can do anything. Some people don't believe it can do anything. And the reality is you can have it summarize Biden's latest speech and say Shakespearean sonnet for him. It works. And another one is, I think, because of the misunderstandings, or maybe just things aren't fleshed out very well yet in the landscape of it, there's fear of HIPAA compliance issues. There's fear of misuse or not enough co-piloting with the AI because it's not going to be perfect. And then who bears the risk or accountability of a mistake? So just some extra thoughts there.
All right, we've got Brandon and then Sean, and if anybody's over here, let me know.
Hi, I'm Brandon Reeser with Elevate PFS. I also moonlight as a rapper, but I will not be quitting my day job anytime soon. So this is a question that I ask every session, but I think it bears being asked. And on behalf of my fellow business partners here, I'm not asking about a service line. I'm not asking about a technology. I'm asking about what are you looking for from us vendors? How can we be of support to you in the midst of all these questions that came up, and it's very chaotic. What was the term yesterday, VUCA? Right? What are you looking for from us, and how can we truly be a good partner to you guys?
I can start. I think the partners that we are most successful with are the ones that are transparent. You know, we are in this together, and we have to know when you can't do something. Or we also have to know if you're going to want to try and do something and you want us to partner with you to try and figure it out. Because I think when you go in with more of those expectations, then you have a better chance of being successful or not being upset when maybe you just couldn't figure it out. I think the other thing is, you know, we often, because of constraints on resources, we often look at our business partners as being the people who day in and day out just live a certain, you know, area of expertise that they do. That's where they do their R&D. That's what they study. That's what they're curious about. They're constantly asking themselves questions. That's, you know, that partner who's constantly evolving and growing and thinking about not what's today's business problem to solve, but what are we going to have in 5 years or 10 years. That kind of forward-looking vision is, I think, critical, because as we've seen, just in the last 3 years since COVID, our worlds have turned upside down in terms of how we do things, in terms of how we staff, in terms of how we manage. So the world can just change pretty quickly when events happen. These cybersecurity attacks are another example of, it's going to change our world. We have to rethink our partnership relationships. We have to rethink how are we connected to people. What are those backup contingency plans? And so I think people that are constantly thinking about, you know, things in that way are going to be a better partner for us. We're constantly changing as a provider organization, and if I don't have a partner who can keep up with that, then that's not going to be helpful.
I'll just add another 30-second response to that. Another piece that I appreciate so much is when a business partner will come in and spend the time to learn my organization so well that they know what I need and what I don't need as well. So, and they might come and say, you know what, I sell this product, but it's not really going to work for you. Let's focus on this instead. You know, taking that time, that's what builds a successful partnership. Because you know what you have, and I know what I have, and we each know those areas better, and somehow we've got to learn enough about the other organization to figure it out. And sometimes we take the time for that, and sometimes we don't, and I think that's where partnerships can go wrong.
Mm-hmm. Okay, Sean, and then we have one more here, and that should probably wrap us up. So.
Great. So I just wanted to comment on that, automating the revenue cycle to replace 2 people when their job is complex and a lot of variability in it. It's about defining the problem, like why are you automating that in the first place? Is it causing pain someplace else? Is there some downstream effect? If you're just automating to automate that work, then it's never going to pay off. Never. It's got to be some broader problem you're solving, you know, utilization across physicians or some better patient outcomes, because those faster answers are going to get them better care faster and improve their healthcare outcome. Otherwise, yeah, it's just automation for automation's sake, waste of time.
Yeah, I think also we learned early on, back in the days of screen scraping, and RPA may have been better technology, but in my opinion, it was screen scraping repackaged. You can automate a bad process, and you're not going to get good results. And automation is a tool that is part of process improvement. I think the difference is AI can tell you where your process is broken and help recommend fixes. So they do different things, but I think organizationally, we're not all technology wizards. I mean, vendors aside, you guys may be, but from a revenue cycle perspective, we know operations, we know people, we know patients, we know, but we're not out there learning how to code AI. If you're a revenue cycle VP and you know how to code AI, let me know, because you're amazing. But most of us don't. And so figuring out what this all means, that's an education process we're still going through. And I think that wait and see thing is where a lot of people are at. Because you hear great ideas, but how you would actually go do it is a very different story. So, name, organization, and question.
Justin Barlow with CASA, a Gen AI company out of San Francisco. Question about the denials trends. There was seemed to be a through line with everybody on the inpatient front, and definitely an uptick in payers denying additional days. Do you feel like the clinicians that are fighting for these, do you feel like they're at a disadvantage because of they don't necessarily have all the documentation they need, or it's difficult for them to find it, or is it something else? Is it just arbitrary, capricious behavior from the payer?
I vote for arbitrary and capricious behavior. And I will say this, that we have a group of physicians that fight these for us, and they will look at a group of denials and go into the peer-to-peer process with 5 to 10 of these cases. And they will rank the cases by what they think they're most likely to win, least likely to win. And they will come back to me and say things like, I won all the ones that I thought were least likely to win, and the ones I was confident about are the ones I lost. It's so arbitrary from their lens. They feel that they have a very strong clinical case. I'm not clinical, right? So I struggle, and I have to believe that what they're telling me they feel very confident in, and that there's not just one provider, but there's many providers looking at this. And the fact that this continues to be their experience is concerning to me, because in my accountant brain says it should be, X or Y. It should not be hidden option C. It just doesn't make sense to me that it would be. So I'm struggling, right? I'm struggling to see the trends there. So I have to go with arbitrary and capricious.
I will say a trend that we continually deal with is that so much of the healthcare world is built on adults, because adults are the primary consumers of healthcare, and we are constantly dealing with the fact that pediatrics is not the same as adults. 2-month-olds are not 60-year-olds. And so I think a great example of that is all the payers who are trying to do ED downcoding, those hidden denials you mentioned earlier. And they're based on algorithms that are based on adults. And so for example, their perceptions about the level of acuity and resources needed for a high fever is very different than if it's a 40-year-old than if it's your newborn baby. Yep. And it's exasperating for us trying to explain that all those algorithms and rules for adults do not fit peds.
Absolutely. All right,
just one quick thing. I do think that the physician has the same struggle that we have, in that the rules change daily, right? Payers change, like what's authorized, what requires an authorization. Can it be authorized as inpatient and outpatient, or just in? Physicians cannot keep up. Nobody can keep up with all those rule changes. And so how do you put information at the fingertips of a physician as they're making a decision to code a certain way, or to, document a certain way, and how do you make that easier for them? And I think that's part of what we're trying to figure out, is how do we help the physician have that information? Because unfortunately, they do now have to worry about these payer rules. Before, they just worried about patient and patient care, but now, since they're not getting paid all the time, they actually do worry about the rules, and they try to follow them, but it's really tricky. So I just one quick thing. Did we answer your question, Sean? I felt like we didn't really answer.
Just commenting
Okay.
that I feel your pain. Trying to automate a
Okay.
process for 2 people is just not going to
Yeah. Okay.
give you ROI.
Okay. Just wanted to make sure. Thank you.
Thank you. I know there's more questions. Thank you so much, but we are out of time, and I want to make sure we get to the next panel as well, the next session. Again, if you need CPE, please see the red iPad. Please remember to log in and give us your feedback on this session, which I'm expecting to be glowing. Thank you so much to each of our panel members. We do have a donation that's been made in your honor to the East Washington Wildfire Fund. And now we're going to go ahead and take a short break before the next session, so you can get up and do some more stretching. Thank you.